Welcome to Around the Room, a podcast brought to you by the Canadian Rheumatology Association. Calling all rheumatology professionals, don't miss the chance to connect with Canada's largest rheumatology community at the CRA Annual Scientific Meeting, hosted exclusively in person in Calgary from February 26 to March 1st, 2025. This year's theme is Ascending to New Heights, Peaks of Innovation in Rheumatology. It will feature groundbreaking advancements in the field with cutting-edge science, exceptional education, and unrivaled networking opportunities. Registration opens November 1st, so save the date. Be sure to register before the early bird deadline of December 13th, 2024. Visit asm.room.ca for all the details. And now, on to Around the Room.
Overall, you actually have more relapses if you stop prednisone once you reach remission versus continuing it for 6 more months. But if you look at the subgroup of people who were receiving rituximab for maintenance, there didn't seem to be that benefit to continuing on with the prednisone.
That's Dr. Arielle Mendel. She is a scientist at the Research Institute of the McGill University Health Centre. She is also an assistant professor in the Department of Medicine, Faculty of Medicine and Health Sciences, McGill University, and a rheumatologist at the MUHC. And she was the first author on the CanVasc consensus recommendations for the management of ANCA Vasculitis 2020 update. We are thrilled to have her as our guest on part 2 of this episode of Around the Room to talk about management of ANCA Vasculitis. Welcome, listeners. I'm Daniel Ennis, along with my fabulous co-host, Dr. Janet Pope. If you didn't listen to part 1 of this interview yet, definitely go do that now. In this second episode, we'll pick up on our discussion on therapy options with the Advocate trial and also get into maintenance and duration of treatment. Let's get into it. Maybe we can talk about Advocate a little bit. Advocate's a really interesting trial, right? This was 330 patients with ANCA-associated vasculitis. They were randomized to avacopan versus standard prednisone taper with standard induction therapies. And it excluded very severe disease, but still had some fairly sick patients in it. And I'm wondering, Arielle, if you can kind of speak to how Advocate, the data from Advocate, how avacopan is kind of being integrated into your practice, given kind of all of this other really interesting data that's swirling around and determining management.
Yeah, well, I've certainly, been trying to get access to it where I can. We'd all like to see our patients off prednisone as quickly as possible. So the idea, if you're going to use avacopan, is, and this was what the CanVasc group stated as their recommendation, is you should aim to completely stop prednisone by week 4. And this is because, this was the requirement in the study. Of course, we know that even after that 4 weeks, the mean prednisone use in the avacopan group was still between 5 to 10 milligrams a day for the first few weeks or so, maybe even the first few months. So, whether any of us feel completely comfortable completely stopping prednisone after 4 weeks, I kind of tend to do that on a case-by-case basis. But certainly when I'm thinking about starting avacopan, my intention is to try to taper off the prednisone as quickly as possible. Of course, this is implying that you're already starting your other induction therapies. So in a clinical trial setting, everybody was getting their rituximab and their cyclophosphamide right away, right as they were starting avacopan and right as they were tapering their prednisone. Whereas you can't really do that if you need to wait a couple weeks to get approval for rituximab, for example. So that's where, things might change. And we also have to remember that many people in the trial may have had up to 2 weeks of steroids before they started avacopan, including pulse steroids up to 3 grams. So integrating it into real world practice is challenging because actually I was going to say this about Pexivast too. I mean, getting doctors to adhere to a specific prednisone tapering regimen where a prescription changes every 1 to 2 weeks is actually, like, outside of a trial setting, is very difficult. So I think real world studies are definitely needed, both for avacopan and for, PXIVAS or other rapid prednisone tapers, because actually the implementation of a prednisone tapering regimen on a large scale is a challenge in itself. And we're studying how to do that really well.
That's a fascinating take. Janet, how about you? Have you had any personal experience using avacopan?
Right. So we've had some at our site. And again, I mean, the difficulty is it's not going to be reimbursed for the people that don't have a private pharmaceutical plan. And I think where we've mostly tried to use it initially, and I'm talking about colleagues even more than myself, because we're all like just a little bit here and there, other than, of course, Lillian Barra has more experience. It's really, sometimes we're thinking of this person is really sick. We're worried about the glucocorticoids for the various side effects, or it is reinduction, that this person has flared now and it was a rocky road last time. Please give us the best care we can. So we kind of are begging for, please give us this drug. So that's where I would say more use right now on repeat flare, so reinduction, because of the fact that we're trying to justify, I think, probably not the safety. I'm happy with the safety. They were trying to justify the cost. It doesn't matter who's paying for it. If it's super expensive, I'd like to be as cost efficient as possible. But I mean, if we could have good coverage for it, I guess that might mean the cost goes down, and or the governments decide, the provinces, that they will reimburse it. I would think this drug should be used in every time we're doing induction, not just reinduction of a sick person that's flared.
I think it's kind of such a disadvantage, because we kind of have this one. There's the 3 randomized trials, but Advocate being one that is kind of this 52-week course of avacopan. And we know the infection rate of that in the trial was identical or very similar to a more standard prednisone taper. But we have just spent a bunch of time talking about how we now have this rapid prednisone taper, and there's also the low VAS taper, and there's other taper regimens out there that are less prednisone. So how would avacopan, do we need 52 weeks, or can you do 26 weeks, or do you only need a month? But at 52 weeks, what if you compare that to a low dose or rapid PXIVAS taper, where the infection rate may be lower? Well, then wouldn't avacopan look worse in certain respects? Do we, so I think there's so many variables in there of like dose and duration and all of that prednisone's kind of way ahead in fact, because it's had multiple different trials and ways of giving it and this and that. We haven't really gotten into the nitty gritty of avacopan. We just kind of know that it has the capacity to replace prednisone in a way. And so I'm not totally sure exactly how it's going to come out in the wash. I certainly lean on it if I have someone who has kind of brittle diabetes, or they have volume overload because they have bad heart failure or other intolerances to prednisone, which I think essentially in many ways aligns with Janet, how you are using it in people who are relapsing and had a rocky road the first time. So I definitely reach for it in those settings, but it's been a bit tricky to overcome my habit of or my comfort even of using prednisone, and I wonder if other clinicians kind of feel that way too.
I think you've nailed it, though, is we don't know where it fits, is the bottom line. And I think of it as another DMARD. So if I can add another disease-modifying drug for their GPA, then maybe that's a win. Well, it should be a win for prednisone compared to the standard regimen tapering, but it might be a win for a patient where we really do need, I'll call it, more safe enough immune suppression. But I think, we'll talk about it in a year or two and maybe have a whole different perspective too with more data that Arielle will collect for us.
Well, actually, Dr. Barr is going to collect it, I think.
Excellent.
Okay, as well.
Maybe we can kind of briefly, although these are huge topics on their own, but we can't keep you forever. I do want to talk about maintenance a little bit. So in your severe patients, what is your preferred maintenance medication?
I am very convinced by the existing trials we have, Mainritsan and Ritazaram, where I believe that rituximab is the best maintenance drug that we have for severe GPA and MPA in most people, except in certain exceptions. People have rituximab allergies or intolerances or something like that. So that is really my go-to drug, and I'm fortunate enough to be able to access it here in Quebec as long as somebody has severe GPA and MPA for maintenance.
And then how about for non-severe disease?
Well, we didn't actually even talk about induction for non-severe disease, but
True, yeah.
I think, whatever they did well on for their induction, I would keep them on for maintenance. So if I gave them methotrexate and they became very controlled on methotrexate, that's what I would continue. And if they needed rituximab in the beginning, well, maybe we talk about continuing with rituximab. I have some elderly people where I'm sort of seeing how they do over time. Just, if we go back to RAVE, they didn't give any maintenance treatment. They just gave one dose of rituximab and then saw how you did over the course of the years. And it was the same thing with Advocate. They didn't give any maintenance rituximab at 6 months. So something to think about in certain people. But in general, I stick with what they were doing well on for non-severe disease. Okay.
And there was a recent trial that was presented, the TAPIR trial on low-dose prednisone. A new trial. I don't believe it's published yet, but did you have any thoughts on low-dose pred as maintenance versus no pred?
Yeah, so that study, I was very happy they did that study. And from what I can tell, we don't have the publication yet, but it looks like overall, if you look at the group overall, you actually have more relapses if you stop prednisone once you reach remission versus continuing it for 6 more months. But if you look at the subgroup of people who were just receiving rituximab for maintenance, there didn't seem to be that benefit to continuing on with the prednisone. Now, could that be because the subgroup was too small? And if you had a much bigger group, you'd still see a signal for more relapses. The other reassuring thing is that all those relapses were minor relapses, and I think almost all of them. And the very interesting thing is, at least in the short term, over that 6-month study, there's no difference in serious infections and no difference in quality of life. And that really floored me because it was open label. Patients knew whether they were getting prednisone or not. And it shocks me that they actually didn't feel like their life had a lower quality with that 5 milligrams of prednisone. And so I think that actually might bring up...
Or better quality.
Yeah.
If they're a better quality.
Yeah, that's true. Maybe they feel better on prednisone.
So what are you doing with that? How has that changed the way you taper or continue that last little bit of pred?
It makes me comfortable stopping prednisone, at the 6-month mark, which is when I think most people would have been randomized into the TAPIR trial. You had to have active disease within the prior 6 months, I believe. So I think it's making it more reassuring for me to do that.
Janet, any thoughts on that? I think that's a really interesting trial too.
Right. So I think the take on it can always be whatever your position was before. You can justify it. See, I can stand for quality life is just the same, blah, blah, blah. They don't flare as much, although the flares are pretty low key because they're being watched really carefully and because they're on low dose steroids. Or steroids are bad, let's get them off because of all the long side effects. So I think you can totally justify. Sadly, a lot of vasculitis trials end up like that. Whatever I thought before, I'll use the data that they give me in the trials to justify what I'm doing, which isn't right or wrong. It's just kind of human nature. But I think we do need, Arielle, you're totally right. I think we need studies like this to say, what the heck should we be doing? This is a chronic disease, because when we talk shortly about, because we're saying rituximab, 500 milligrams, IV, Q6 months until whatever. I mean, eventually, despite a chronic disease, we do try to think of drug-free remission, which might be a segue, Daniel, for your next
exactly.
question.
That's really great. I totally agree. You kind of can see what you want in that trial, but I think it's so fascinating and such an interesting topic.
Are you seeking a community dedicated to advancing rheumatology care, education, and research? Welcome to the Canadian Rheumatology Association. At the CRA, we're more than just an association. We're a community of passionate professionals united by a common mission to promote the pursuit of excellence in arthritis and rheumatic disease care, education, and research. With us, you're not just a member, you're part of a dynamic community dedicated to supporting you in every step of your journey. From career advancement to patient care, join the CRA today and experience the benefits. Enjoy organized networking, invaluable advocacy initiatives, curated training and education, grant opportunities, resources for clinicians, students, researchers, allied health professionals, and so much more. Together, we'll shape the future of rheumatology in Canada and beyond. Join our community by visiting rheum.ca and become a member today.
So, duration of treatment. How long should patients, let's start with severe. How long do severe GPA or MPA stay on your maintenance treatment of choice, rituximab?
I think most recommendations, including the Canadian recommendations, we recommend that we continue at least 2 years of maintenance treatment with rituximab. And 2 years, you could get your last dose at the 18-month mark, which would give you rituximab exposure ostensibly until 2 years. I tend to actually give it longer than that. And I think it all has to do with how long your payer will pay for it. Now in Quebec, once it's approved by the government here for somebody with severe GPA or MPA, you never have to renew it. It's just approved indefinitely. And so that's really when we have to ask ourselves, well, when is it appropriate to get you off of this medication? I think we can see from studies like MAINRITZ 3 that if you stop maintenance treatment after 2 years, there's going to be some people that flare, but it's not everybody. It's maybe 75% of people actually stay in remission for the next 2 years. And so who are those people who are going to stay in remission off treatment? I think we have to go back to what we know about risk factors for relapse. So having a prior relapse, having PR3 ANCA, somebody who's, never, their ANCA's always stayed sky high positive despite being on, I don't know if that's evidence-based, but that's kind of how I feel. And then you also have to look at what's at stake. So could this patient tolerate another relapse? And also, how well are they tolerating the rituximab? Are they having infections left, right, and center? So that's another question. I think a lot of these questions would be interesting to do a study looking at patient preferences, because it could be that patients would rather just be on treatment very, very long term until there's a reason why they have to come off of it. Or it could be that they'd prefer, given the potential risks or infection, or, especially with the COVID pandemic, very severe COVID outcomes and lack of response to vaccination, they might want to, take a holiday, like a drug holiday from rituximab for a while.
That's what we call it when we take someone with a chronic relapsing disease off treatment. We call it a drug holiday. Do you divide, though? You mentioned PR3 as a risk factor for flare, but are you more inclined to say, okay, MPA, so they're MPO positive, pulmonary renal syndrome, would you, because those patients may be monophasic, are those patients that even if they're severe, you would say we are going to stop at 2 years and we're going to see what happens? Do you treat all of your severe GPAs for 4 years on aggregate? or are you actually stopping GPA patients at 2 years and seeing what happens? You pointed out that the minimum is 2 years, but you could go longer. And I'm curious if you have a pattern of practice there that you tend to follow, because I tend to lean more towards 4 years for a GPA, because they're likely, like, PR3 positive, GPA, severe disease, because they really are relapsers. And a quarter of people relapsing is a bit frightening for severe disease. But do you have a feeling about that?
I think that's actually similar to what I do. I think if I have an MPA patient and they don't have other risk factors that I think they have for relapsing, I think at the 2-year mark, I start talking to them about, do I really stop at cold turkey? No. I actually say, why don't we try going 8 months and see how you do, or maybe going a year. And, that is one option. In the recommendations, we also suggested you could try doing the main Ritsan 2 approach, where you retreat if their B cells repopulate or if their ANCA comes back positive. Now we have data from this main CanVasc trial that actually retreating based on B cells will give you fewer relapses for sure, but numerically more COVID infections in that group, and also numerically more people dying. So there's always trade-offs.
Janet, what do you think? Is that a similar approach that you take, or do you treat longer, shorter?
Right. So anybody who is hard to get into remission or relapse with with what we'll call serious disease, because sinus disease, I don't know if I ever get rid of it, and if you ever retroorbital mass and proptosis, I don't think it ever fully goes away, but their double vision improves. They get a bit less proptotic. But we'll talk about the serious or the moderately serious that are on rituximab. I think 2 years for most of them is short, and I don't feel that worried about infection when it's 500 Q6. That's only a gram in a year. Now, when they get to 4 years, some are really like their IgGs might be going down a bit, but I kind of often say to them, in RA, we've had people on rituximab for almost 20 years now. I guess 15, 18 years, when the initial trials were a long time ago. I might be exaggerating, it's probably like 15 years, but the trials were a long time ago, and most people didn't have serious infection. A lot of people eventually in their RA were in long-standing remission, didn't even need drug anymore, where they got treated over and over. So I kind of try to help compare that way. But I think there is a patient preference. And say if it's a young person, a woman, and they're contemplating pregnancy and renal, but they're great now. Their GFR is really in the normal, the mid-normal range where it started out. And their clock is ticking, 36 years old, say. I'm going to say, do you want me to give you another rituximab and you delay yet another 2, 4 months, 6 months, whatever, before you want to consider pregnancy? But these are the exceptions to the rules. So again, I think I'd rather go 4 years than 2. I have some people that stop at 2, and I have some people that after 4 years, I go, I don't know what we're doing, but I feel comfortable treating you and uncomfortable stopping because this was your third flare and you keep pinging off function or you get some organ damage. So I think we just divide them up. You're low risk, in my mind, of bad problems if you relapse, or you're low risk of relapsing, and you're higher or highest risk. And those latter two groups, higher risk, just I like to treat them. I feel very comfortable using rituximab long term, but I say this is eminence and evidence free beyond even like the 4 years.
We've been taking up a lot of Dr. Mendel's time here, so I think I'd love to kind of pick your brain about infection prophylaxis, but I think we're going to have to save that for another time. Is the
Could I ask one question? In a yes or no, Arielle, if you're on high enough dose glucocorticoids and you're on immune suppression with severe ANCA vasculitis, Septra with Bactrim, yes or no?
Yes, I always give.
See, here you go.
Yeah.
There we have. Yeah, I knew the answer because you've done lots of wonderful work in that area, looking at systematic, looking at a big, large population.
That's exactly right. Dr. Mendel has done some really nice work on infection prophylaxis and even did a presentation at ACR on it. I think it's, a public service announcement for our ANCA Vasculitis patients that we continue them on sulfatrim while they are on their rituximab, and then usually don't stop it until 6 months after their final dose of rituximab, as per the CanVasc guidelines. Is that so, Arielle? Is that fair?
Well, I've been thinking more and more about that. And honestly, most of the data we have is really in the first year of starting rituximab. And I think that that's another area where we really don't know the right answer about when to stop antibiotic prophylaxis. And maybe it's okay to stop after a year if you find that their absolute infection risk is very low. If you're reducing their infection risk in half, but they were only going into it with a 2% risk of a serious infection over the next year, you might argue maybe you don't need it. But I think that's another thing where patient preferences might come into play.
Thank you so much for all of those insights. I follow your career with personal interest, and I always love seeing your name on publications. So I really appreciate you taking the time. It was so nice to talk to you.
Thank you so much for having me, Dan and Janet.
Thanks for coming. That was really helpful.
That's it for this episode of Around the Room. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag our Twitter account with your question at CRASCRRoom. Around the Room is produced by David McGuffin, Dr. Dax Rumsey, and Aaron Stewart. We'd like to give a special thanks to the Communications Committee and the staff of the CRA for their hard work. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. And share this episode link with your colleagues. It helps these interviews reach as wide an audience as possible. Until next time, I'm Daniel Ennis. Thanks so much for listening.